Welcome to the August Radicle Community webinar. My name's Timothy Byars. I'm the president of Radicle Health, and I'm joined today by our CEO, Eloise Theisen. These webinars are included in our Radicle Community membership. They are free to all members and also now to the general public. For those of you who are new, the Radicle Community is comprised of advocates and educators and healthcare professionals, cannabis stakeholders. So what we want to do is we want to provide support and information and resources to our members. So for information about how to join, you can go to our website, radiclehealthcare.com, click on the community link. It's free to join, but when you sign up through the website, you can get access to our seasonal newsletters and also to our on-demand video library, which includes recordings of all of our webinars, as well as additional interviews and other media. I also want to remind everyone that we have an array of curriculum options at a range of price points for students and working professionals. So whether you're helping customers make good product choices or treating patients or advocating for social change, or maybe you're just using cannabis yourself and you want some more information, you need well-cited, factual information about cannabis. So Radicle Health curriculum is up to date, it's comprehensive, and it's informed by clinical experience and by instructional design expertise. So you can either reach out to us for information, you can click the education link on our website, you can click either of these two links on the slide and get to where you need to go to see what the curriculum looks like.
Okay.
So this presentation today is for educational purposes only. And the information presented today is not intended to be a substitute for medical advice. It's not meant to help in the diagnosis, prognosis, or treatment of cardiovascular or any other virus, disease, illness, or condition. For any of you who are using warfarin or Coumadin, please know that cannabis can affect your INR levels and can put you at risk for increased bruising and bleeding. So tell your primary care physician if you're using cannabis with warfarin, monitor changes in your prothrombin, and please notify your Coumadin clinic that you're starting a cannabinoid therapy and monitor for any signs of bleeding. So this month we're doing cannabis and cardiovascular disease. And the reason is because earlier this month, the American Heart Association released a fairly comprehensive statement about cannabis and cardiovascular health, and it's here on the slide. It was titled Medical Marijuana, Recreational Cannabis and Cardiovascular Health, a Scientific Statement. So while the report did acknowledge that cannabinoids have, quote, potential therapeutic and medicinal properties, they also stated this. They said cannabis may have therapeutic benefits, but few are cardiovascular in nature. Conversely, many of the concerning health implications of cannabis include cardiovascular disease, although they may be mediated by mechanisms of delivery. The resulting internet headlines were both breathless and alarming. This is the one from CNN. It's not so bad. Weed is not good for your heart, studies say. But there are others. Some of my favorites are millions of cannabis smokers at risk of deadly heart attack and stroke, doctors warn. Another one was American Heart Association warns marijuana is a substantial health risk. Another, smoking and vaping cannabis can trigger heart attacks. And then my favorite, could marijuana break your heart?
Oh, God.
So we wanted to do what we do, which was we wanted to look at the literature and see what was out there. I know personally I haven't looked at this issue too closely. But when I did look at the literature produced in the past 30 years about cannabis and cardiovascular disease, it's somewhat overwhelming for a couple of reasons. One is that the language itself is really challenging, especially for a layperson. But two, there's a lot of literature, and a lot of it is conflicting. Most of it consists of case study reports, things like letters to the editor. There are a few large observational studies. The one thing that most of these have in common, most of the literature published have in common, is that they stridently declare the mortal risks of using cannabis. So we're going to start tonight with what we know. And what we know is that smoking cannabis, combusting cannabis, can have multiple negative effects that can lead to cardiovascular stress and potentially more serious issues in persons with existing cardiovascular problems. And so those issues include the following: increased heart rate or tachycardia, increased myocardial oxygen demand and decreased myocardial oxygen supply, increased carboxyhemoglobin levels, and increased endothelial dysfunction. And if you're like me a month ago, you don't know what any of those things mean. Maybe you know what tachycardia is. So we're going to talk about each one of these. But before we get started, what I want to point out is that these are all risks that are related to smoking any organic combustible material. So cannabis can also increase blood pressure and contribute to orthostatic hypotension. That's a sudden decrease in blood pressure. Sometimes you feel it when you stand up too quickly and you get a little dizzy. We're going to talk about those two separately and later on in the webinar. But let's review these first five. So what's tachycardia? It's a condition characterized by rapid heartbeats. So for adults, a heart rate of more than 100 beats per minute is considered too fast. Now, when the heart beats too rapidly, it pumps blood less efficiently. And this reduces blood flow and subsequently it reduces oxygen to the rest of the body, including the heart itself. You know, there's blood flowing through the heart constantly, but the heart it's a muscle, it's tissue, and it needs its own oxygen supply itself. And that's, it gets that oxygen supply from capillaries. When the heart's beating rapidly, the muscles in the heart are required to work harder and they need more oxygen. So persistent tachycardia can lead to oxygen-starved cells in the heart, and this can lead to a heart attack. And we think that THC produces tachycardia either through CB1 receptor activation in the heart, so there are receptors, CB1 receptors in the tissue, or it might produce tachycardia because it can stimulate the sympathetic nervous system. This is the part of the nervous system that modulates rapid involuntary responses to dangerous or stressful situations. You know this as the fight or flight mechanism. Now, stimulation of this part of the nervous system can increase heart rate, it can increase blood pressure, and it can increase oxygen demand. So what are myocardial oxygen demand and supply? So like any tissue in the body, the heart requires an adequate blood supply and amounts of oxygen for optimal function. So myocardial oxygen demand is the amount of oxygen that the muscular tissue in the heart requires to work properly. Myocardial oxygen supply is the amount of oxygen the heart receives from blood delivered by the coronary arteries. So under normal conditions, we want the demand to equal the supply. Now, heart rate is one of the most important factors affecting myocardial oxygen demand. Again, when the heart rate increases, the heart's muscular tissue has to work a lot harder to pump the blood to the rest of the body. We know that THC can produce tachycardia. This increases heart rate, and therefore it increases the oxygen demand of the heart muscles. So this can lead to myocardial ischemia. This is an inadequate blood supply to the heart, and it prevents the heart muscle from receiving enough oxygen. All right, what about carboxyhemoglobin levels? Our red blood cells carry millions of proteins. They're called hemoglobin, and these proteins facilitate the transport of oxygen throughout the body. So these are oxygen molecules. They bind to 4 different sites on the hemoglobin. And under normal circumstances, oxygen binds to hemoglobin. It binds in the alveoli. Remember our COVID talk. You inhale oxygen, it makes its way down through the respiratory system to the alveoli, to the small sacs, and that's where gas exchange happens. And then the hemoglobin picks up the oxygen and it gets distributed throughout the body, and the oxygen gets released where the body needs it. When you smoke cannabis or when you burn or combust any material, any organic material, that combustion can produce toxins. Those toxins include things like tars and carbon monoxide. Carbon monoxide is colorless, odorless, and poisonous. So when you inhale carbon monoxide, it also binds to hemoglobin in the red blood cells, and it forms a molecule called carboxyhemoglobin. So carbon monoxide actually binds to hemoglobin about 200 times more efficiently than oxygen. And because it binds so tightly, there's a very slow rate of release. And there starts to develop an accumulation of these carboxyhemoglobin molecules. And subsequently, you have fewer hemoglobin proteins that are available to bind to protein, and to bind to oxygen. And this reduces the amount of oxygen that's distributed and that reaches organs and muscles in the body. So effectively, you're poisoning yourself. You're creating carbon monoxide poisoning. And this carbon monoxide poisoning is associated with a number of cardiovascular issues. These include things like cardiomyopathy. These are sort of a general diseases of the heart, angina, which is chest pain, acute myocardial infarction or heart attack, arrhythmia, cardiac failure, pulmonary edema, and sudden death. All right, so lastly, what's endothelial dysfunction? So this is a common predecessor to cardiovascular disease. It's damage to the vascular endothelium. And the vascular endothelium is a single layer of cells that makes up the inner lining of our blood vessels. Again, recall our COVID talk where we talked about endothelial cells. They're the things that keep the inside of us inside and the outside stuff outside. And damage to this lining can impair the function. And it causes a condition called endothelial dysfunction, it's characterized by inflammation and blood clotting and impaired vasodilation. So we need our blood vessels to expand and contract as our blood pressure increases and decreases. And preventing damage to the vascular endothelium can minimize the risk of developing cardiovascular disease, including heart attack and stroke. Now, again, any type of smoking can damage endothelial cells, including cannabis. And also, while it's not entirely understood yet, there are some researchers who think that chronic activation of CB1 receptors can also contribute to endothelial dysfunction. But there's still some work to do in that field. These are risks. These 5 things are risks that are associated with smoking any organic combustible material, and the risks of smoking cannabis as well. We also wanted to take a look at the research and ask whether just the use of cannabinoids specifically potentiate adverse cardiovascular effects. So let's take a look at some of the research. If you do a simple internet search and you use the terms cannabis and heart attack, you will likely return information quoted from a 2001 study. This is where researchers determined that the risk of a heart attack is nearly 5 times higher in the first hour after cannabis smoking. Now, this study is ubiquitous on the internet. It's on websites like Healthline, the American Heart Association, the American College of Cardiology, BBC News, ABC News, MarketWatch. It was cited in the National Academies of Sciences, Engineering, and Medicine's comprehensive 2017 report. I've seen it on Harvard Medical School's website, the CDC, CNN, and I've seen it published or cited in multiple published medical papers. Again, 5 times the risk of a heart attack during the first hour after smoking cannabis. That's really alarming. The details of the study, however, present a somewhat less salacious conclusion. So the study was led by Murray Middleman. He's at Harvard Medical Center. It included almost 3,900 patients, and they were interviewed between August 1989 and September 1986. All of these patients had heart attacks. And of these 3,900 patients, 124 reported smoking cannabis within 1 year of their heart attack. 37 patients reported smoking cannabis within 24 hours of their heart attack, and 9 patients reported smoking cannabis within 1 hour of their heart attack. Remember, that's what this study is about, a 5-fold increase in the risk of a heart attack 1 hour after smoking cannabis. It's based on 9 patients. 3 of these 9 patients reported either using cocaine or having sexual intercourse within 1 hour of their heart attack. The conclusions of this study are based on 6 patients, essentially. And according to the numbers in the study, smoking cannabis is estimated to account for a smaller proportion of heart attacks than air pollution. So when this study came out, in response to it, the Lynn Smith Center, this was the predecessor to the Drug Policy Alliance, they stated the following. They said that an analysis of the research methods used in the study reveals glaring flaws. The sample size is statistically insignificant. No causal relationship had been established, and the study itself has never been replicated. The sample size alone renders the results meaningless. And then finally, they said, assuming that Dr. Middleman's conclusions are correct, the fact that heart attack risk for an otherwise healthy 50-year-old man is about 10 in 1 million highlights the sensationalism of the widespread publicity the study is receiving. There is another statistic that appears consistently in internet articles and also in the medical literature, and that's that in patients with chronic stable angina, smoking a single cannabis cigarette decreased exercise time to angina by 50%. So angina is chest pain. Chronic stable angina is the kind of chest pain that gets worse when we expect it to get worse. So if you have chest pain and you go out and exercise vigorously, your chest pain probably is going to get worse. There's also another kind of angina called unstable angina, and this is the kind of chest pain that you can have at rest, for example, but we're talking about chronic stable angina. So in other words, in this study, what they found is that people with existing angina will feel chest pain sooner when they're exercising if they smoked cannabis before exercising than if they did not smoke cannabis prior to exercising. Again, this is an oft-cited statistic that seems to be taken as acknowledged fact in the medical literature. This statistic is cited from a single study completed in 1977, 10 male patients who were asked to smoke 18 milligrams of THC before they started exercising. So take it for what it's worth. This is the Cardia study. This is a very well-respected study. It's coronary artery risk development in young adults. It's a long-term study of cardiovascular disease beginning in young adulthood. So this study included over 5,000 adults. They were aged 18 to 30 at the beginning of the study, which was in 1985, 1986. Researchers followed these participants for nearly 30 years, and they estimated their cumulative lifetime exposure to cannabis with assessments. They brought these people in for examinations every 2 to 5 years. Now, the study intended to examine the incidence of cardiovascular disease in this patient base. And they concluded, the researchers here concluded that compared with no cannabis use, cumulative lifetime and recent cannabis use showed no association with cardiovascular disease, stroke, heart attack, coronary heart disease, or cardiovascular disease mortality. They also found that cannabis use was not associated with cardiovascular disease when stratified by age, gender, race, or family history. This was a study done by a team of investigators at Harvard Medical School in collaboration with Beth Israel Deaconess Medical Center. So they collaborated on a prospective study to assess the use of cannabis among patients with existing heart disease. And they wanted to test whether cannabis use is associated with an increased risk of death. So this study included nearly 4,000 heart attack survivors who were studied over an 18-year period. And you can see what their conclusions are. They stated that in this prospective multi-center cohort study of myocardial infarction, survivors followed prospectively for up to 18 years. There was no conclusive evidence of an association between smoking marijuana and mortality. This is our old friend Madeline Meyer and her colleagues at Duke and Arizona State Universities. They published a longitudinal comparison of persistent cannabis users with persistent tobacco users. So they used data from the Dunedin study. This was data collected from about 1,000 individuals born in New Zealand between 1972 and 1973. And they followed these patients, the patient data for about 38 years. So Meyer and her team wanted to test how cannabis use between the ages of 18 and 38 was associated with physical health at the age of 38, even after controlling for tobacco use, childhood health, socioeconomic status. They found that tobacco use was associated with worse lung function, worse metabolic health, and systemic inflammation at age 38 years. No surprises there. Regarding cannabis, they stated that cannabis use for up to 20 years is associated with periodontal disease, gum disease, but is not associated with any other physical health problems in early middle life. So poor Madeline Meyer, she keeps trying to find something wrong with cannabis and keeps coming up empty. Now, there are studies that seem to suggest an association with cardiovascular risk and cannabis use. They tend to be either isolated individual case reports or larger studies that include confounding factors like tobacco or illicit drug use. So this is one example. This is a study published in 2013. It suggested an association between a, quote, cannabis lifestyle that includes tobacco, end quote, and ischemic stroke. So we know demonstrating an association is not the same as proving causality. Also in this study, nearly every patient with a positive cannabis screen also tested positive for tobacco use. So the researchers here noted that, quote, further research is required to clarify whether there is an association between cannabis and stroke independent of tobacco, end quote. Now, this is a case study report that was published in 2014. This describes a healthy 21-year-old man who reported to the emergency department in Wales. He had sharp pain in his chest while he was playing soccer. It lasted 30 minutes. He had a heart attack. He was both a regular cannabis user and a tobacco smoker. Now, he had also reported cocaine use, but he'd said that that use was not recent. For some reason, his doctors identified his cannabis use as the most significant precipitant of the attack, and they published this case report. So I'm not sure why they decided that it was the cannabis, but here's part of the reason why they came to the conclusion. Quote, though cannabis is not commonly regarded as a risk factor for this diagnosis, there is evidence that cannabis seems to be a rare trigger factor for myocardial infarction, with the risk being increased by a factor of 5 in the first hour after smoking it. So this was a study by NIDA, National Institute on Drug Abuse. So this was a seminal review. It's well respected. It was co-authored by the director, Nora Volkow. It was published in the prestigious New England Journal of Medicine in 2014. So what NIDA did is they summarized the research on cannabis, and they tried to identify their overall confidence in the evidence of adverse effects of cannabis. Now, certainly, many of us can take issue with these estimations of confidence. That's a battle for a different day. I think what's notable here is, though, what's not listed, and that's cardiovascular risk. This really underscores the fact that there is a great deal of ambiguity about whether the data has any association between cannabis and heart risk. So at this point, really, most of the studies that we've been talking about, they're focused on cannabis-related cardiovascular risk related to smoking cannabis. So we want to also look at risks associated with other routes of administration. So there's one case study that was published in the Canadian Journal of Cardiology. It was a 70-year-old man with a history of heart disease. He was hoping to reduce his osteoarthritic pain and improve sleep. He consumed an edible that contained 90 milligrams of THC. So within 30 minutes, he was hallucinating and he was having severe chest pain. So he went to the hospital. The doctors determined that he did in fact have a heart attack. And they stated that they believe that the large dose of THC put a sudden and unexpected strain on the man's heart and triggered the attack. It's well established that ingesting cannabis, especially at high doses, can produce acute anxiety, panic attacks, and tachycardia. These are all symptoms that can strain the heart muscle. I also want to mention that there have been at least 4 published case reports, individual case reports of myocarditis associated with cannabis use. And in one case, the condition led to heart failure and subsequent death of an 11-month-old child who had ingested cannabis edibles. So myocarditis refers to the inflammation of the heart muscle. It's typically caused by the immune system in response to some trigger, and that trigger usually is something like a viral infection or a chemical toxin. So in all of these reports, it wasn't clear whether cannabis itself was the cause or if there were possibly contaminants in the products, things like pesticides or heavy metals that contributed to the condition. So clearly, the risk of using cannabis, especially smoking cannabis or ingesting large doses, that risk is not 0. But the overall effect of cannabis use on the frequency of heart attacks remains at best unclear. The research suggests that cannabis will likely not cause a heart attack in a healthy person. Now, there are small studies, there are individual case reports that suggest that cannabis can trigger heart attacks with people, especially with existing cardiovascular disease. The risk remains low, especially if they're using routes other than inhalation. Cannabis, and specifically THC, can produce side effects. We know it produces tachycardia. It can produce hypertension and vasoconstriction with initial use. These are side effects that are dose dependent. Some users will actually develop a tolerance to these adverse effects. But patients with underlying cardiovascular use should discuss cannabis use with their healthcare professionals. Now, the Canadian Federal Department, Health Canada, they've also weighed in on the evidence examining the effects of cannabis on cardiovascular health. And basically, they've said that it's inconsistent and insufficient. In fact, they said this: while cannabis is known to cause peripheral vasodilation, postural hypertension, and characteristic conjunctival reddening, that's red eyes, after smoking, the most consistent acute physiological effect of smoking cannabis is dose-related tachycardia. And while cannabis-induced tachycardia is not usually considered dangerous for healthy young users, it may be dangerous to those already suffering from cardiac disorders or angina, end quote. So just to put a final point on the research, This was a study that came out recently. It was a comprehensive, systematic review of the literature published between 1975 and September 30, 2017. Their conclusions were this. Evidence examining the effect of marijuana, diabetes, dyslipidemia, acute myocardial infarction, stroke, cardiovascular, and all-cause mortality was insufficient. Although the current literature includes several long-term prospective studies, they are limited by recall bias, inadequate exposure assessment, minimal marijuana exposure, and predominance of low-risk cohorts, end quote. So clearly there's more work to do here. Insufficient data does not mean absence of risk. Cannabis is not entirely benign. We know that there are adverse effects, especially when you're combusting it, and especially in patients with existing cardiovascular conditions. Now that said, I'm not convinced that the research warrants the type of excessive hand-wringing that we've witnessed in the media since the American Heart Association released their statement. So at this point, I'm going to turn it over to Eloise. She's going to talk about cannabis and hypertension. She's going to maybe discuss whether there are any benefits to using cannabis and cardiovascular health. I think she's got a couple of case studies to go over, and then she's going to give some recommendations for clinicians and for patients. So, Eloise?
Thank you, Tim. Appreciate it. That was great. Go ahead and advance the next slide. So, I think you pointed out some really great things, Tim, in the previous slides, and the one with the Canadian study was really talking about dosages and how the different dosages can have, of course, different side effects. And really, most patients up to this point have been self-exploring cannabis and haven't had the luxury or the accessibility of a clinician to help them determine the right cannabinoid profile and the right dose for their specific conditions. I want to talk a little bit about some of the other cardiovascular concerns with cannabis. Often when I'm working with other clinicians or students, we're talking about how cannabis can affect blood pressure. We're also talking about heart rate, atrial fibrillation, and potential drug-to-drug interactions. So that's what I'll focus on a little bit now. And with cannabis and hypertension, we know that high blood pressure is the most common cardiovascular disease. Blood pressure is the measure of the force of blood pushing through the artery walls. Just a quick review. And over time, high blood pressure can damage our arteries and lead to life-threatening conditions. Things like poor diet, stress, physical inactivity, alcohol intake, and tobacco use can increase the risk of developing hypertension. So currently it's estimated that about 30% of adults in the United States have high blood pressure. Next slide. The higher number is let's start that over. The higher number is the systolic pressure, which represents the force in the arteries when the heart beats. The lower number is the diastolic pressure, which represents the pressure in the artery when the heart rests between beats. Blood pressure will vary in a healthy adult, rising and falling with changes in activity or emotions. We know things like pain can influence blood pressure, often causing it to rise. Dehydration may cause us to have low blood pressure. We consider a normal blood pressure to be about 120/80 in a healthy adult, and a high blood pressure is diagnosed after 2 high blood pressure readings that exceed 130/80. Next slide, please. And studies suggest an association between cannabis use and increased systolic blood pressure. Researchers in this study found no association between cannabis use and hypertension or prehypertension. Studies also revealed no association between lifetime history or cannabis use and blood pressure levels. But we do know that we've seen in some of our patients when they first start consuming specifically THC that their blood pressure can rise and their heart rate can also rise for about 10 to 15 minutes after cannabis inhalation. And so some experienced cannabis users will develop a tolerance to these effects. There's an example of a study where they surveyed over 12,000 US adults and suggested a modest association between recent cannabis use and increased systolic blood pressure. I will say The data revealed no association between cannabis use and diastolic blood pressure levels. Researchers detected a statistically significant association between recent cannabis use and high pulse pressure, but found no association between cannabis use and hypertension or prehypertension. And finally, the study revealed no association between lifetime history of cannabis use and hypertension. I just said that earlier. Conversely, a small double-blind study with 9 healthy men suggested that 600 milligrams of CBD increased heart rate but decreased systolic blood pressure. And most recently, I actually had, next slide please, a gentleman that wanted to use THC for his sleep apnea. And what was really interesting was to find this information here because he started to experience an increase in his blood pressure. And he had had a normal blood pressure. He was an 86-year-old retired physician. And I put him on a very low dose of CBD and THC. It was a 2-to-1 THC to CBD. And his total combined dose of the 2 cannabinoids was about 3 milligrams. And his blood pressure actually went up to about 150/90. And his primary care physician wanted to put him on high blood pressure medications. And, we did talk about how there's the potential, which I'd only seen at this point with inhalation, for THC to raise blood pressure initially. We stopped the cannabis at night, his blood pressure returned to normal. So what's interesting is that your posture can actually impact the effects of the THC on your blood pressure. When we found this information, that when using THC lying down, studies suggest that it can elevate blood pressure. We can also see studies that show THC can cause a drop in blood pressure when standing up, which Tim was referring to earlier, that orthostatic hypotension. And of course, the sudden drop of blood pressure can cause dizziness, sometimes even fainting. So in certain populations, we want to be really careful that they're not at risk for falls and potentially, injuring themselves if they have that sudden drop. So it's really important that anybody, like Tim mentioned, who has a history of any kind of cardiovascular disease gets a thorough workup from a cannabis clinician to determine the risks and benefits and if it's even appropriate to proceed. Next slide, please. So are there any cardiovascular benefits to using cannabis? We know that it can be an effective treatment for symptoms related to a broad range of conditions and diseases. And so the answer is yes. Next slide. There are multiple potential cardiovascular benefits of using cannabis. What you're seeing here is the C-reactive proteins, and they're made up in the liver and sent to the blood as a response to inflammation. And we know that inflammation can be measured by the levels of the CRP in our blood. And so when you have a higher level of CRP, the C-reactive protein, it's associated with a higher risk of heart attack. And preclinical studies suggest that very low doses of THC may be cardioprotective on experimentally induced myocardial infarction. Now, patients with angina based on the spastic contraction of the coronary arteries might benefit from the antispasmodic effects of cannabis. And also, cannabinoids reduce platelet aggregation and can reduce the tendency of the blood to form clots. And this is really where I want to clarify. A lot of people refer to cannabis as being a blood thinner, but we know it can reduce platelet aggregation, which is different than thinning the blood. When we look at anticoagulants like warfarin, Coumadin, that's going to thin the blood. Antiplatelet drugs such as aspirin and some cannabinoids prevent these blood cells called platelets from clumping together and forming a clot. And finally, cannabinoids are potent anti-inflammatories. So again, I think there are some benefits for the heart that we should really be doing more research on to see which dose and which cannabinoids are most effective. Next slide, please. And then we have metabolic syndrome conditions, which increase the risk of heart attack, stroke, and type 2 diabetes. And it is a condition that increases blood pressure, high blood sugar, excessive belly fat, and high levels of cholesterol and triglycerides. A study was published in 2016 and analyzed over 8,000 subjects ranging in age from 20 to 59 to explore the relationship between cannabis use and metabolic syndrome across stages of adulthood. Researchers concluded that cannabis users were 54% less likely than subjects who never used cannabis to present with metabolic syndrome. They concluded that the current cannabis use is associated with lower odds of metabolic syndrome across emerging and middle-aged US adults. Next slide, please. And now with, of course, the emergence of CBD, we're seeing a lot more focus on CBD research. And there's some research demonstrating that CBD might reduce heart rate, blood pressure, and of course, anxiety. Excuse me. It should be noted that the adverse cardiovascular effects of cannabis are specifically associated with THC up until this point. So this is exciting about CBD. And a 2008 study in rats suggested that CBD can reduce increased blood pressure and heart rate in response to stress in a dose-dependent manner. We are hearing more and more information come out about how CBD improves our response to stress. These same researchers noted that CBD also decreased anxiety and that all of these effects were likely mediated by our 5-HT1A receptor activation. And just as a reminder, CBD is an agonist at our 5-HT1A receptors. And in a 2017 study, healthy human volunteers were subject to stress and given a dose of CBD and had statistically significant lower blood pressure compared to volunteers who were given a placebo. Now, it was just a single dose study, so more research is definitely needed in this area. But as Tim was referring to earlier, a lot of times things like stress and poor diet and lack of sleep often can contribute to cardiovascular disease. And so maybe there's an indirect way that these cannabinoids are also helping cardiovascular health. Next slide, please. So I want to give a couple examples of using cannabinoids, particularly with warfarin, because recently I've had a few people who have been telling me that if someone's on Coumadin, that they tell them it's an absolute no for cannabis. And I really haven't seen these extreme reactions or drug-to-drug interactions with warfarin and cannabinoids. I am going to show you a couple different routes of administration where clearly the cannabinoids affected the INR levels. But again, because there's such a small therapeutic window with warfarin, what you want your patient to let their healthcare practitioners know, like we stated in the beginning, is I'm starting cannabinoid therapy. I expect my INR levels to fluctuate while I'm exploring my dose. And once they find that dose, their INR levels typically stabilize. Just like when we're trying to educate them about changes in their diet, we want them to be consistent, right? It's not that they can't have leafy green vegetables, it's just that they can't binge on them. So this is a 68-year-old male with a history of hypertension, AFib, and chronic pain. He had actually had an ankle injury in his 20s and used ibuprofen chronically to deal with his pain and inflammation, and as a result developed AFib and hypertension. His medications include warfarin, atenolol, and Tylenol as needed. He was no longer able to take the ibuprofen once he was put on warfarin. His INR levels had been stable for over a year, so his blood tests were only every 6 months, and he was within his therapeutic window of an INR of 2 to 3. And he wanted to start cannabinoid therapy for chronic pain because the Tylenol really wasn't cutting it. And his, when he was able to use the ibuprofen, he actually got really good relief. Next slide, please. So we decided to initiate a combined cannabinoid tincture, which was CBD, CBDA, THC, and THCA. And the total combined dose of all of these cannabinoids was 5 milligrams twice a day for pain relief. And initial INR levels increased with the tincture to over 3, just slightly over 3, and his Coumadin dose was adjusted, and his INR stabilized actually within a month. Because we found that that 5 milligram dose twice a day actually really helped his pain quite quickly. So we were able to get his pain under control with cannabis, so his dosages of cannabis weren't fluctuating. I did have him go in for his INR level about 2 weeks after he started the tincture. And then we decided to try something for sleep, and we added in CBD with a 30-to-1 tincture at night at around 25 milligrams. And after 6 months of being on this other tincture, and his INR levels actually became sub-therapeutic, which was really bizarre to me. I really expected his INR levels to go up again. So his INR had to be adjusted. It took about 2 months with the CBD dose before he got back within that 2 to 3 range. Next slide. And this is a 72-year-old female with a history of AFib and insomnia, and she had a long history of tobacco use. And we also know that tobacco can affect the INR levels. The only thing that she was taking was warfarin. She wasn't on any other medications. She'd been stable for years, and she wanted to initiate cannabinoid therapy for sleep. Next slide, please. She had difficulty falling asleep, and she wanted to explore inhalation first as her route of administration. And I recommended a THC indica dominant chemovar, advised between 2 to 4 inhalations before bed to help assist with falling asleep. I did have her notify her primary care physician so that she could get her INR levels checked within about 2 weeks. And it did increase beyond 3 just with inhalation, actually within that first week of inhalation therapy. So once she found how many inhalations she needed to help her to fall asleep, her Coumadin dose was adjusted and her INR levels actually stabled within about 3 weeks. Next slide. And it's really important when working with the patients who are using Coumadin to let them know that, they may, if they have any increased signs of bleeding, I always tell them if you're brushing your teeth, if you go to the bathroom and there's any blood in your urine or in your stool, you're having excessive bleeding, bloody noses, notify both me and your primary care physician right away. So really, for clinicians, I think it's really important if you're working with patients, you're always assessing for things like chest pain, edema, heart palpitations, arrhythmias, low blood pressure, and orthostatic hypotension. And be aware that many cannabinoid naive patients may report tachycardia, which of course is a common side effect of using cannabinoids. And it's an adverse effect that can be resolved after repeated use and when we control the dose. Of course, when working with geriatric patients, especially patients using anti-hypertensive medication, ensure that you monitor for orthostatic blood pressure. Always include precautions and safety recommendations in the treatment plan. If they're feeling dizzy upon standing, do they feel lightheaded? Have them check their blood pressure at home if they can. And avoid starting cannabis therapy for patients with unstable or newly diagnosed atrial fibrillation or recent myocardial infarction. There are situations where I have required the patient to get permission from their cardiologist before beginning any cannabis treatment. Next slide, please. And recommendations for patients. The risk of a heart attack when using cannabis might be similar to the risk of a brisk walk or sexual intercourse. But nevertheless, if you're a patient with existing cardiovascular issues, always notify your cardiologist, your Coumadin clinic, and other healthcare providers before beginning a cannabis regimen, and always work with an experienced and qualified healthcare professional. Of course, we still recommend going low and slow. Consider starting with a non-impairing cannabinoid such as CBD, CBDA, or CBG. Always encourage patients to monitor and report side effects such as increased heart rate, increased or decreased blood pressure, and dizziness. Take note of any potential drug-to-drug interactions. For example, does a prescription feel stronger or weaker when you use it in conjunction with your cannabinoid medicine? And again, it can't, stress it enough. Make sure if you are on Coumadin that you're keeping your cannabis dose consistent so that those INR levels do not fluctuate.